And now please allow me to introduce our speaker today, Professor Yu Jie. She is a chief physician from International Ultrasound Department in Chinese PLA General Hospital. Thanks to Professor Yu for joining us today to share her great experience in thermal ablation. Professor Yu's topic today is thermal ablation of breast cancer. Professor Yu, please.
Okay. Good afternoon, every doctors and professors. Welcome to this meeting and communications from so many countries, from European and Asian countries, to share our knowledge and progress of thermal ablation of breast cancer. I'm Dr. Yu. Now I will share some knowledge of breast cancer ablation. As everyone knows that breast cancer with incidence rate in the and the second mortality among all the malignant tumors among female cancers. For the history of the local treatment for breast cancer from about 130 years ago, from hosted radical mastectomy to extended identified radical mastectomy. And now, in recent 40 years, breast cancer surgery has become the mainly part of the less invasive treatment for the breast cancer. So for the patients and for the doctors, the less invasive treatment is a tendency of the breast cancer. So thermal ablation development from the 1994, including cryo, RFA, laser, HIFU, and microwave. All of these thermal ablation techniques has been used for the breast cancer with the advantage of the minimally invasive scarless cosmetic and favorable effects, and with the ablation zone gradually shrinking, and even after 1 to 2 years unpalpable. And this technique allows for the lesions to be treated repeatedly and for the new recurrence lesions, and without the radiation treatments non-toxic and radiation. For these 5 kinds of the ablation treatments, RFA and cryo are the 2 mainly techniques among all these 5 techniques. With about 60% of the papers used these 2 kinds of ablation technique to treat breast cancer in the past 20 years. For the lesion size, less than 2 centimeter lesions is the major part of the breast cancer, but it's a new technique for breast cancer with only 69 papers has been published all around these 5 techniques. So has many study oriental for the ablation of breast cancer. Though RFA is the most technique for the breast cancer ablation, but this technique has published its paper about 10 years ago. Not in recent 10 years, not very many papers have to research on this technique. And according to the double word, we can say this studies is with the lesion only be treated by the FRA and without the post-operative reaction. So we can see from these 4 papers the effective of the RFA not resected by the surgery with no recurrence, no metastasis, and no death for this early stage, very early stage breast cancer, but the sample is relatively few. And for other techniques, laser and cryo has all published for this less than 2 centimeters lesions. And with the red papers, we can see that they are without the resection after the ablation. So we can see, according to the medium follow-up with this ablation treatment, the recurrence rate is very low incidence for the ablation of breast cancer. And the minor and major complications is low. By now, there are only one paper to publish with the high-level evidence-based medicine for the breast cancer ablation. It's published in the top journal of our image radiology. It's published 5 years ago. It's an RCT study with 20 persons in the RFA treatment and 20 persons patients is the RFA plus the lumpectomy for the early stage breast cancer. After the treatment, the positive margin shows that RFA is very good effect, even better than the resection, significantly less than the positive margin of the resection. And during about 2 years follow-up, there's 3 cases occurred the infection in the RFA area. I think this may be because of the chemotherapy and radiotherapy. It's a risk factor for the infection after the ablation treatment, but no infection in the surgery group and no recurrence or second operation needed for any patients. So this paper has got the highlight from the radiology with very high evaluation, a step forward for the breast cancer. And other studies without the subsequent lumpectomy for the breast cancer, such as laser ablation for the old age female patients with less than 15 centimeter and even 20 millimeter breast cancer shows no recurrence and residual tumors. So it's an effective and safe technique for small lesions. The technique effect is improved with the skill improvement of the doctors. From before the 29, and we can see that the complete ablation rate is only 75%, but in recent 5 years, this CA rate has improved to 90%, especially for the small lesions. So it's safe and effective. In our group, we focus on the microwave ablation treatment. So in the following presentation, I will mainly introduce the microwave technique, but it's also commonly suitable for other techniques. I think not only microwave or other techniques for breast cancer, the standards is necessary for this treatment. We think there are 5 specifics. The first one is we need to provide pathological and molecular type before the ablation for the lesions, and to define the auxiliary lymph node metastasis, and to stage and the boundary of the tumor on the imaging and perform the completeness of the tumor ablation. And the last step is to evaluate the necessity of the adjuvant therapy. For the first step is to define the ablation protocol and to define the lesion size, margin, and blood supply, and the adjacency. On the ultrasound imaging, it's very important for it's very clear for the breast tumor and its convenience. And another imaging is CEUS, contrast enhanced ultrasound. I think is also necessary for this treatment. And the MRI is also necessary imaging because we can evaluate the the lesion's shape, size, and margin with another more clear and with more, a higher sensitivity imaging. Before ablation, we also need, after the imaging detection, we also to perform the ablation protocol to clear the puncture route, ablation needle type, and ablation power or time, and auxiliary technique such as the dissection technique and anesthesia method. The indications for breast cancer, I think for the curative treatment, it's less than 2 centimeter is most suitable for the ablation treatment. And if the lesion apart from the nipple and a histological negative for the sentinel lymph node and no metastasis of the axillary lymph node on the contrast enhanced image, including MRI and the US, is most suitable for the ablation treatment. Apart from these very early stage lesions, and palliative ablation is also okay for some large lesions, and for some lesions, patients lose the surgery chance for the comorbidity, and some young female patients to refuse surgery for the requirement of the cosmetics and the minimal invasion. There's nearly no significant contraindications for the breast cancer ablation. Just for some patients with severe dysfunction of the blood coagulation or the severe cardiac or pulmonary insufficiency, maybe it's not suitable for ablation. Just before ablation, I think in this meeting, many doctors are surgeons, so they think the management of lymph node is very important. So for the surgeon, they have advantage to deal with the lymph nodes about the. For the sentinel lymph nodes, we think we should perform the biopsy firstly, and if the lymph nodes with the micrometastatic, so we should perform the axillary lymph node dissection. And for the with patients without the positive lymph node metastasis, we can perform ablation treatment. And during the treatment, the ablation margin evaluation is very important. So we should perform the evaluation both on the CUS and on the MRI. It's very impossible to perform the ablation margin at least with 5 millimeter for this tumor. Even for some lesions in the safe location without adjacent to the skin or without adjacent to the nipple, we will with the ablation margin large than 10 millimeter, I think it's better. So before the ablation treatment, we should perform the core needle biopsy with the needle size larger than 16 gauge to provide enough tissue to give the pathological diagnosis and the IHC diagnosis results to guide the chemo and target treatment. This is the scenery of our treatment. We perform ultrasound-guided ablation. This is the needle of our microwave from the Kanyo company. Its size is 16 gauge. And this is the dissection technique needle with a 20 to 22 gauge PTC needle. And for the treatment, we should enlarge the lesion size with enough ablation zone to encompass the complete tumors. This margin is the lesion, but this error is our ablation area to cover the tumor completely with enough ablation margin. There are two technical points. The first one is liquid isolation zone for the lesions adjacent to the important tissues, skin or the nipples. We should perform the liquid dissection technique with the PTC needles. This lesion is adjacent to the skin, and this is the PTC needle to infuse the liquid. And the second technical point is the power and the moving short ablation technique, just as the thyroid ablation, but different from thyroid ablation is that the power of the breast cancer ablation is higher than thyroid with more than 20 watts for the lesions adjacent to the skin or nipple, but for the lesions in the safely located area, we used about 50 watts with a long duration for every site ablation. For thyroid, maybe 10 seconds for every site ablation, but for breast cancer, maybe 30 seconds or 1 minute is necessary for the every ablation site. This is the needle tip enlarge the lesion, and this is the small lesions. After puncturing the lesions from the deeper site, we can move in the needle to the superficial site of the lesions. And there are several papers to publish on the ablation treatment compared with the surgery treatment. There are 3 microwave papers and 1 RFA papers to compare these two techniques. During the study results, we can see that there's no difference for the tumor progression after treatment, and the OS, there's no difference. This study is performed by our group. In 3 years ago, we published with the microwave versus 2 nipple sparing mastectomy for less than 5 centimeter breast cancer. Why we choose for these larger size tumors? Because most of the patients with very early stage tumors, they will not choose ablation, they will choose the surgery. And many patients without the chance to surgery, they will wait and with the tumor progression to the 4 to 5 centimeters, they only know our technique and to our department to for the effective treatment. So most of the ablation treatments with the tumor size is larger. So we can't perform the lesions perform the study with a lesion less than 2 centimeters in the initial period of our study. And we performed 21 patients in ablation group and 43 in the NSM group. After treatment, the ablation needs less hospitalization. Maybe this technique can be treated at the outpatient, but we need to perform some chemotherapy, so we perform the patients in patients and need less operation time, and estimated blood loss is fewer than the surgery. After treatment, the cosmetic satisfaction is better for the ablation treatment with very good, about 100%, but for the NSM, about 25% of patients is not very satisfied for the NSM for many reasons, for them not with not very good cosmetic appearing. And for the tumor recurrence and survival, there's no difference. And this is the volume shrinking after the ablation. This is the tumor at the baseline size volume, and it's ablation because we will perform the enlarged ablation, so the tumor volume will enlarged. And after about 6 months, the size and the volume of the ablation zone will decrease significantly. And another study we performed the comparison between microwave with the breast conserving surgery, still for the less than 5 centimeter patients. Before the PSM, we have 21 patients in ablation group and BS group with 85 patients. This data is from our center. It's a one center study. And we performed the PSM with both of the group has 21 patients. Just as the last study, we can see that the ablation treatment shows the advantage of the less invasion with less adenomer drainage. Nearly, we don't need the drainage after the treatment and need less ablation duration and estimated blood loss. And even for the cost, it's very important for patients. Ablation treatment, I think maybe in this study, it's a little higher than surgery. It's because of the few part of the patients performed 2 sessions of ablation because the size is 5 centimeter. After the evaluation of the MRI, we think the safety margin is not enough for these patients. We perform another second session ablation, so the cost will increase. But for the cosmetic results, we show the advantage compared with the BCS treatment. The mainly unsatisfaction for the patients is 2 reasons. It's the scar formation. Another is asymmetry for these patients after the BCS treatment. This is the third study performed by our group. It's for the 2 to 5 centimeter breast cancer. Because for less than 2 centimeter breast cancers, it has been verified that the breast cancer ablation is effective. But how about for the 2 to 5 centimeter is also the early stage breast cancer.
So ablation has been proved as a safe and effective technique in the local therapy of different solid tumors. But the application of breast cancer is still in the exploratory stage, and no study has investigated the clinical outcomes between microwave ablation without subsequent lumpectomy and breast conserving surgery in patients with 2 to 5 centimeter breast cancer. In this 2-center retrospective study, 224 patients with 2 to 5 centimeter breast cancer were treated with microwave ablation and breast conserving surgery. Propensity score matching was performed at 1 to 2 to reduce bias in the evaluation of treatment effects, and the baseline characteristics were well balanced after matching. The median follow-up period was 33 months, and primary outcome was tumor progression, which had no statistical difference between the 2 groups both before and after propensity score matching. In addition, as the secondary outcome, disease-free survival and overall survival also had no significant difference between microwave ablation group and the breast conserving surgery group. It is worth mentioning that in the evaluation of cosmetic results, patients treated with microwave ablation reported better cosmetic satisfaction as compared to surgery-induced confusion of breast asymmetry and scar formation. Finally, survival models were established to validate the results of tumor progression and disease-free survival, and all the p greater than 0.05.
Okay, this is the third study. And the fourth study performed by our group is for the 3 centimeters, because many surgeons suggested us that more than 3 centimeters is suitable for ablation treatment, so we should perform the evidence for less than 3 centimeters, just larger than 1 centimeter than the less than 2 centimeter lesions. So we performed this study from about 10 centers from all around China to collect the patient's data with microwave totally with 172. This finished in this year, and with the BCS treatment after 1:1 ratio PSM balance, there are 96 patients in each group with a very balanced power in this study. This is the results, part of the results of this study. Just as the past 3 studies, the results is consistent. And this is disease-free survival, because this is inline of the log rank figure. So we can see there's no difference for this DFS before and after PSM. Not only for the DFS and for the OS. The median duration for this study is 3 years. And for the subgroup analysis, this is for the less than 60 years old patients, and this for older patients. There's no difference for the DFS. And for less than 2 centimeter lesions, and for the larger lesions, there's no difference for the DFS. Now we will show 2 cases for every doctors and professors. This is the most suitable lesions for ablation treatment, lesions with 3 centimeters in the safe located breast, just as the MRI and ultrasound shows. And 3 days after ablation, it's just like a cried egg imaging on the MRI. It's the necrosis ablated lesion, this high intensity lesion. And this low intensity area is the ablation zone. And this is the 6 months post ablation treatment, 1 year, 2 year, and 3 years, 4 years with a long-term follow-up for these patients. We can see that the ablation margin is very clear. And this is a 4th-stage breast cancer with ulceration. It's 85 years, very late, and he has lost the effect in the long-term medication treatment. And pathological findings that the right invasive breast cancer with many axillary metastases. And the tumor has very severe bleeding before treatment, so the patient has the hemoglobin level only 99 gauge per liter. We performed 2 ablation sessions for these patients. They use the ablation needle with 11 millimeter tip length under the general anesthesia, for it's too large, and maybe without anesthesia it's too painful for these old patients. And this before and after treatment MRI imaging. This this line is before and this after treatment. We can see that the enhanced contrast enhanced MRI shows this low intensity area is ablation zone covers the entire tumor. And on DWI sequence, we can see no imaging of the lesions. And just about 1 month after ablation is the scar of the ablated area. And 2 months after the ablation, the scar slowly disappeared. And about 5 months after ablation, this is 5 months after ablation, the skin is curable. So the technique, if we perform complete treatment for these tumors, we can improve the survival time and the quality of the life for these patients. They can have the bath and the painful. And this patient is another patient with skin invasion for the tumors about 4.5 centimeters. The skin has been invaded by the tumor and with the metastasis lymph node. Because his ear is okay for surgery, but he refused to perform the surgery. So we perform ablation for the entire tumor, even for the part of the tumor part invasive to the skin. We perform ablation with the liquid dissection technique, and we perform the ablate for the lymph node, axillary lymph node. So we think the ablation is very effective and promising technique for many breast cancer patients. We organized a prospective multicenter study 2 years ago in China, and we will welcome all the online experts to join us to perform this comparison study to perform microwave ablation versus to breast conserving surgery for the less than 30 centimeter tumors to provide the evidence for this new technique. Maybe have a high-level evidence for this technique, we can development and promote this technique to widely use in ablation in clinical. So make a conclusion for my presentation. Microwave is minimally invasive and effective for breast cancer, and complete ablation is a key technique to achieve good effect. And volume reduction effect was satisfactory for both benign and malignant lesions. So don't worry about this. Thank you for your time and attention. You can contact with me by email or by WeChat or by phone. Thank you. That's all.
Thank you, Professor Yu, for the great presentation. Thank you. And I think we have some questions from the chat box. Professor Yu, so here are some questions we got during the presentation from the doctors, from the audience. Could you please help to do some discussion on this?
Okay, for the first question, it's for the metastatic lymph nodes. If the patients have the indications for the surgery with the metastasis lymph node, I think the first choice for these patients is surgery with the lymph node metastasis. But for some patients with the less than 3 lymph nodes metastasis or with the negative metastasis diagnosis before the clinical negative lymph node metastasis diagnosis. We think microwave is okay because after ablation treatment, we will perform ablation and radiation treatment. I think it's supplementary for the ablation treatment to treat the potential metastasis in the lymph nodes and in other parts. I will answer all the questions.
Yes, I think so. Yes, please. Thank you.
Okay. Ablation margin and how can I measure? Ablation margin is at least larger than 5 milliliter. I think it's must to perform. If the lesion's location is okay, you can perform maybe larger than 1 centimeter ablation margin. How can I measure? If you perform ultrasound guided ablation treatment, we can see the gossip, the necrosis lesion, and the ablation zone on the ultrasound imaging. And we can see the difference of the margin of the ablated zone and the ablated lesion on the CEUS. And the last protection technique is to perform MRA after ablation treatment. I think it's most sensitive and most accurate for evaluation the margin. So we perform these three kind of the imaging to evaluate the ablation zone. During the procedure, we perform ultrasound and CEUS. And after ablation, we perform MRA. So there are about 5% of patients in the beginning of our work. About 5 years ago, about 5% of patients will perform the second session ablation treatment. But in recent 5 years, because our skill material, there's no necessary for the second session. Does ablation have any role regarding recurrence? For the early stage breast cancer, less than 3 centimeters, only one patient occurred the recurrence, local recurrence, about 4 years after ablation. It's the first patients performed by us. We use the RFA treatment because about 10 years ago that patients were treated. It's our first patient. We have not very mature experience. So we perform the not very enough ablation margin, about 1 milliliter margin only. So these patients occurred the local recurrence at 4 years after treatment. My measurable power is decided by the lesion location. If the location is just in the middle of the breast, it's far away from the nipple, from the skin, and from the muscle, I think the power don't need to change. But if for the lesion adjacent to the nipple, maybe less power, lower power is more safe, I think. Will you ablate triple negative? Yes, we have treated many triple negative cancers. According to the surgeon's recommendation and suggestion, they think the triple negative cancers is okay for the BCS treatment. So we think it's okay for the ablation treatment because the most high risk for the triple negative cancers is not the recurrence in the breast, but in the liver and in the lung to occur the recurrence and metastasis. How do you address the axillary ridge is essential for It's a challenge for our interventional ultrasound doctors. For the sixth question, I think it's a challenge. We perform the evaluation by the three kinds of the image technique. So we only evaluate the clinical negative lymph nodes metastasis. According to many high-level researchers, that for the clinical negative lymph node study breast cancer tumors patients, it's okay. There's no difference between the survival and the DFS between these patients to perform the lymph node dissection or without the lymph node dissection. Resection. How do you? The second question, what about HER2 positive cases? From our study about 100 studies, in our fourth study, there's no difference between HER2 positive or negative cancers between two groups. For the eighth question, what about the suspicious microcalcification around the lesion? I think there's this imaging character shows no side effect or negative effect on our ablation treatment. We can ablate all the tumors, including the microcalcification. For the next question, what is the role of microwave in bilateral multi-breast fibroadenoma? I think it is most suitable for the benign lesions, especially for the large fibroadenoma, because for many young patients, the fibroadenoma is with commonly with multiple lesions. It's a very good choice for microwave ablation. I think it's better than the surgery without no scar, and we perform ablation treatment for maybe 30 lesions during one session for this benign lesion tumors patients. The 10th, what about the protocol of treatment after the ablation? This is just the same as the BCS treatment. If the patients have the indication to perform the radio and chemo treatment, I think it's necessary to perform all this treatment. But for some patients with low risk, such as less than 2 centimeter and more than 65 years old and with a lower score after the 21 gene detection, so maybe it's not necessary for chemo. We think we could don't perform the chemo or radiotherapy. And for some patients with more than 80 years old, they are not candidate for the chemo, can't tolerate the chemo and radiotherapy. Don't perform these two kinds of treatment after ablation. I think it's okay for these elder patients. Why not we take FNAC of lymph nodes visible on USG for staging? What's a FNAC? Sorry, I don't know this. Could you tell me, Shen, Manager Shen?
So I think so. Dr. I think it's from Dr. Nitin. So could you please help to describe your questions again for Dr.
Yeah, my question was why don't we take FNAC or visible axillary lymph nodes for at least for staging purposes if we are ablating? If we can do that, we can provide a better staging for the cancer, and we can decide on whether we need a axillary dissection after ablation or not. It is just a point for discussion. I also don't know the answer, to be specific.
Yeah, maybe it's a good choice for surgery. But for we will perform the FNA. It just refers to FNA. We perform FNA, but not FNA, but CNB diagnosis for the lymph node. All the patients before ablation treatment, we perform the 3 imaging scan and perform the CNB diagnosis for the lymph nodes. If the lymph nodes is positive, we will perform the further detection, such as the axillary resection. But for the CNB diagnosis is negative, and we think the patient is clinical negative metastasis. We will perform ablation treatment. According to this protocol, there's no patients occurred the recurrence in the lymph nodes after ablation treatment because most of patients perform chemo and radiation treatment. Do you consider tumor biology for ablation? Yeah, we will consider it for the HER2 positive and triple negative breast cancer. We will perform larger ablation zone and we will recommend the patients to perform the target and chemo and radiation treatment for the HER2 positive breast cancer. And for the triple negative cancer, we will perform the chemotherapy and radiation treatment. Does the lesion disappear after ablation? I think most of the lesions will not, most of the ablation zone will not disappear during 5 years because the ablation zone is relatively large than the benign tumors. So it's very difficult to disappear, but they can soften after during the long-term follow-up, and they can shrink during the follow-up. So I think it's not a challenge for patients. Did I get it right? Ablation can be performed to all lumina A, B, HER2, and yeah, I think so. But there's no very high-level evidence for us to provide this suggestion. I think according to our study, about 100 patients, I think it's not affected by the sorry. I think it's not affected.
Thank you, Professor Yu.
Perform the neoadjuvant chemotherapy, but only for patients according to the NCCN guidelines. If the NCCN guidelines recommend neoadjuvant chemo, we will perform such as the larger than 3 centimeters lesions and some HER2 positive lesions, we will perform it. What is the post-ablation follow-up imaging protocol? There are all the imaging protocol is 3 kinds of imaging. Ultrasound is the first line imaging. All the ultrasound scan. And if there's suspicious lesions around the ablation zone, we will perform MRI and even we will perform biopsy for the ablated lesions. If sometimes MRI provides the diagnosis with BIRAS 4, level 4, we will perform biopsy for these patients. if we have opportunity, we will share some this knowledge of the evaluation technique for you.
Okay. Thank you, Professor Yu. Thank you, everyone. I think that's all questions for today. And due to the limitation on time, maybe we cannot answer all questions coming up. So we can all discuss on that in the future. And I think we wrap up for today's meeting. Thank you, everyone. Thank you, Professor Yu.
Oh, thank you. Thank you, every experts from all around the world. Welcome to China. Welcome to our group to share some experience to communicate, and welcome to join us to perform the international multi-center study to provide the evidence and the effect for this new technique. Welcome.
Thank you.
If necessary, you can contact me by email. Thank you.
Thank you. Okay, bye-bye, everyone. Bye-bye.
Bye-bye.